Welcome to another session of Let's Talk Sickle Cell. I think this is our second meeting for the year. Today we have a very, very interesting topic. We have a talk from Miss Diana. She's a hematology nurse specialist at the Korle-Bu Teaching Hospital. And we also have a talk by two other people, namely Praise and Sheila. So if you are ready, I guess we can start. So Miss Praise, are you around? Or Sheila?
Hello.
Yes, Praise, how are you doing?
I'm fine, and you?
I'm fine, thank you. So let me do a quick introduction for Praise. We'll have a small talk by Praise, Vivian. Jide, is it Jide?
Yes, please.
Okay, Praise Vivian Jide. She's a 31-year-old lady and a proud beautician living in Pando in the Volta region. She has been on the Sickle Cell platform for about 2 years now, and she would like to share an experience of Sickle Cell with stroke. So, Miss Praise, you can go ahead with your small presentation.
Okay, thank you very much. Okay, it all started with my small girl. Her name is Treasure. We are on admission. That was in June, early June 2018.
Wait, I can't hear you. Can you be a little louder? Sorry.
Okay. I'll be talking about my small girl called Teresa.
Teresa,
Please,
okay.
Can
everybody hear her? Okay, you can go ahead.
Okay. So it started as we were on admission at Pando. So I don't know. It says I knew nothing about. I know there's something called sickle cell, but I knew nothing about stroke and those sort of things. So we were there, and she was just getting swollen. So I asked her referral. She went to her. She was there. She went to coma, and in the coma she was having something called seizure at the left side. Well, she was at the coma for a month. So after the seizure, the doctor told me that your daughter has a nerve stroke at the left side. I said, how? A 4-year daughter with a stroke. How? The doctor said it's possible. I said, I knew nothing about sickle cell stroke. And I knew nothing about small children having stroke. So first I was scared. And I was told that you'll be discharged. And I said, oh, doctor, how can I? The baby was making before he came to the hospital. The baby that was, he said, the hospital is not good for you. You have to go home. It wasn't an easy task. Yes, let me say it wasn't an easy task. So within the school, they say you should be coming for 50 in therapy. Every year you have to take from one to go for physiotherapy because they say we don't have any good people finance. You should be coming to you. So we've been doing there, but I don't know. She was scared of the machine that are in the room. She will not compare. And at the time, she became very heavy. She was very thin, but she became very heavy. So I have to carry her all along. So one day I came across a page on Facebook called Sickle Life. So I just joined, asked them question on Messenger, and I came across Dr. Joan Bankers. So she said I should come to reach. I said I don't have my sister, I should come. So we went there. That was when I was told that it's possible. Even when what we have was first stroke, it can happen more than the first one that we have. So ours was even the starting point. I said, okay. So we were there. Even that time, her eyes were not even yellow, more than the color called yellow. And the urine was like a Coca-Cola. So we were at the reach for almost 2 weeks and we were discharged. After we went back to physio again, and they say your condition is not good, so you'll be on admission again. I said no. Even she's not working, so everywhere I have to go, I have to carry her along. So how can we be on adrenaline again? And said they have to test. So that was where we even tested Hep C again. And I said, doctor, my small girl has mild stroke. The urine is not changing. You said even the kidney is about to get damaged. And now we're talking of Hep C again. And I called Dr. Inam and she told me it's possible. And I said, wow. So they said they should refer us to Korle-Bu. I said, well, we don't even have any money again, but they said we should go. So we went to Korle-Bu. That was where I got a lot of counseling that it's possible my daughter can have stroke. And what we even have now is just the beginning. So if care is not taken, it will be more than that. So we've been there for 2 weeks. Every week I have to go for review from Pando to Korle-Bu, carrying my small girl with stroke with my bag from Volta to Accra almost every week. It isn't an easy task. So we've been there and we were told about bone marrow and the money we can't afford it. So we were just managing the physio and our normal folic acid, Zincovit, and penicillin V. So as time goes on, the urine is changing. We do a lot of tests at Korle-Bu. So the urine is changing. But what normally makes me sad is, I know maybe there will be a parent here going through the same thing, I don't know. If she's sitting down, maybe she has forgotten that she can't walk. If she's sitting down, she will just do as if she wants to get up, then she will fall and say, Treasure, what are you doing? She said, Mama, I want to walk. Oh. And I said, but you are not walking. He said, I'm walking. So at time goes on, if I said, okay, let me wear a dress for you, bring your hand. Then this little girl will tell Mama, where is my hand? I can't feel that I have a hand. And I said, bring your hand. He said, Mama, where is my hand? And that time too, I was about getting fed up. So what I'll do is I'll just beat her. Then she'll cry. That would tell me I shouldn't beat her. I said, let me wear a dress for you. You are telling me where is your hand? Why you know you have 2 hands? You bring the second one. Then she'll tell me, Mama, where is my hand? Where is my hand? So after I was getting the counseling, that's why I knew that although the hand is there, but she's no more feeling it, that she has a hand. And she'll be forcing me, Mama, I want to go to school. I said, Amiram, you are not working. So if you go to school and it's break time, what will you do? And I said, my teacher will bring me out. I said, no. Your colleagues will be laughing at you, so you should be in the house. So we've been going to Korle-Bu. If you are back, then we'll go to physio at Trafalgar. So one day we came to work. I came to work. I brought her along. So she said she was not feeling fine. So more time she said, Mama, I'll poo-poo. Then I'll give her chamber pot at the workplace. So I went home. She started vomiting. She will vomit and running stomach at the same time. I said, what's happening? So the dad said I should send her to the hospital. I said no. Because I was told we got the Hep C through a transfusion that we got at my place. So I was scared of sending my small girl to that hospital again. So I told the father that we'll pass the night, then the following morning, we'll go to Korle-Bu again. And I said, okay. So it was at dawn. Even now, she will not wake me up again. As soon as I get up, all the bed is full of vomit. And I said, Treasure, why didn't you wake me up? She told me, Mama, I thought I was worrying you because you were sleeping. I said, but look at how you did the bed. I said, Mama, sorry. So it came to a time she said, call me my dad. The dad was not there, so I called him and he came. And she started talking as if somebody that is not normal. I said, Daddy, buy me hand glove. My hand is paining me. Daddy, buy me sauce. And Dad said, Treasure, you have glove. He said, Daddy, buy me another one. So the dad said we should go to the hospital. I said, okay. So he brought us to town and I picked a car. That was at the dawn. At dawn, like 4 o'clock. So we set off and we were going. I even want to put her pampers, but the dad said because the way she is, he thought we'll be going to Margaret Makwa. So he said if we reach there, I should put her. I said, no, I'm not going there. So now we're going. She was screaming in the car, doing. So everybody was saying, "Oh, is she sick?" I said yes, and the people said, "Oh, she's suffering." I said yes. So on our way, she stopped screaming again, and everybody was saying, "Oh, maybe she has a relief," and you all said yes, yes, yes. Don't win. My small girl is no more. I don't know. So we were going so that she went to toilet in her dress. So I feel like putting on the pampers. So I put her on my laps. But after changing putting on the pampers, I saw that she has not moved. I remember that the time that she was in the coma, if the doctor came, they prick her and she has not moved, then the doctor will use her fingers to press one side of her chest. Then she'll get up. She will do, then she will open the eyes. So I tried doing that, but she did not wake up. So there was an old lady sitting beside me. I said, "Ma, please look at my small girl for me." Because it was still dawn, the woman put on her torchlight. And I saw that there was some light watery coming out of her nose. So the woman said, And I said, "Ma, what is it?" And she said, "No." And I said, is my daughter dead?" She said, "No." That's why I said, "Doctor, please stop, driver, stop." And the driver stopped. So there was a man that we picked just on the way. The man just got up and said, "What is wrong?" in our language. And I said, "It's my daughter." And the man so the driver stopped the car and the man just walked to my place and took the small girl from me and removed the glove with the sauce and everything. And she said, and the man said, her hand and her legs are all very cold. So the driver should branch to one clinic on the way so that she should check. And I said, "Okay." So we went there and the nurse asked me, "Why are people going?" I said, "We are going to the hospital." "Where?" And I said, "Trafalgar." And she said, "Why not the hospital at your place?" And I said, "No, we've been referred to Korle-Bu, but I thought Korle-Bu is far. So from Trafalgar, maybe that's why we'll take ambulance and go to Korle-Bu, that's why." And the nurse said, "Okay." So the nurse told me we should go to Trafalgar, that she's still alive, so we should go. And I said, "Okay." Not only because of the way I was behaving, that's why the nurse said she's still alive. So after I get out and demand that she's dead, the driver then passed through my end so that you alight us there. So that after you went to alight the passenger, then you come for them. And I said, "Driver, what is wrong?" And he said, I know that's why I just called the name. I said, "What is wrong?" And he said, And the man said, "They said your child is no more," in our language. That's why I screamed. Not only the time that she stopped screaming, meaning she's no more, but because I've not been through it before, so I don't know. I was just still holding her on my laps. So that was where the doctor alighted us. That was where the doctor alighted us. The driver alighted us at the man's place. So the man said, she called just a small girl, "Call my mom." So the mom came and the mom saw the man holding a baby. The baby she's helpless, she's just weak. So the woman screamed, "What happened to your daughter?" And the man said, "She's not my daughter. We're in the car coming and this happened to this lady." The woman said, "Oh, sister, you are too young to watch this early morning. You've not even eaten." That time, it was around 5:30. So we were alight over there and the driver went to go to alight the passengers. After that, he came back and picked her. So even the old lady was telling me that she wants to accompany us to Pando. And the driver said, "We'll manage." So they put my small girl at front and I was at the back. She was with the driver. I was at the back. So the driver did not even pick anybody on the way coming again. So when we are coming, that driver picked and the dad said, "How far?" And said, "Oh, boss, your child is no more." And the dad said, after I went to wee outside, the way the small girl was talking, he knew she's gone. That's why he said we should go to the hospital at my place. But because of what they did, I said I'll not go there. So he just said he's not surprised. So I should tell me that I should take her for me to reach home. I said okay. So because I've not been there before, I don't know. Before reaching home, they said they have even went for the grave already. And I asked why, and they said in our culture because she's our only child and we've not been there before, so they will not keep her down. That's how we get home, just bath her because she's almost 2 months to 5 years before she passed away. So they say she's now older than a carton. So that gets some small coughing, and that was where my small girl left me since from that day up to now. So my small advice to those mothers with our strong warriors is, please, if you go to hospital, at times if we ask questions, the answer that I know the doctors are listening, the nurses are listening. The answer that we need from you people, at times we don't get it. At my place, if you went to hospital with a child, let me say SS or SC, they'll just be telling you, you are just enjoying yourself. You will not test. You see what you for the small girl. Mhm. Excuse me to say, I'm not all that educated. I'm just a JHS liver. So they are saying that I said I knew nothing about sickle cell, and instead of them to talk to you in a manner that when you get home or you think of something, they'll just be putting the blame on you, telling you stories that will give you a lot of regret. You see how you let a small girl suffer. Instead of you to go and test, you are just enjoying yourself, moving from here to here. Do you see now? Leave the father, otherwise you give birth to that same child again. No. And I said, wow. So right now, if I leave the father, where am I sending this small girl to? Almost every 3 months, we are at the hospital. Every 3 months, we are at the hospital. Why am I sending her? So I just wish that we should bring the teaching to our local towns to, because up till now at my place, people thought my daughter passed away through those taboo, or they said because maybe I ate something when I was pregnant and somebody didn't like it. That's why every time my daughter is getting sick, some people say we should send it to the GP so that they'll bath her, they'll give her mark, then she'll not fall sick again. So after I came across Dr. Inam, I learned that is even I was not the first person to give birth to a special child or a strong warrior. But at our place, a place in the Volta region, my family people, they will put a lot of blame on you, and it will even come to a time even your let me say your family people, that's the father side, they'll be talking as if maybe your child that is sick, or maybe it's your womb that is not good, or maybe you did something and the consequences is coming. They'll be putting a lot of blame on you. So after I get to Trafalgar, that was why I heard that even it's not good for the dad to give my daughter blood, because he's also a carrier. And I said I knew not the dad donated blood almost more than 15 times for the small girl. And they told me that like they should transfer somebody who is AA blood to her. And I said, oh, I knew nothing. Even at our place, and every time the dad is donating. So let me say, those child that we have, I will say, although I'll not wish to have one again, but what I've witnessed for this 2 months to 5 years is just a good experience, because my small girl, let me say, she has a lack. We reaching Trafalgar, at times we don't buy medicine again. One day, one of the student nurse was our nurse. They said, "Oh, treasure mother," they say you should be doing frequent transfusion. I say, And where am I getting the blood from? Even the money that I'll even pay for, I don't have. So this nurse went to UHAS campus at Ho. I just don't know how he did it, but a lot of students came aid that they want to donate blood for my semester. So they even donated blood, maybe even more than 15 units. So we just a little from it, and we went home. They'll just come to our aid
Okay,
with
so
a
that
lot of
means
provision. Hello.
so what I'm gathering is, and outside the cities, we don't have that many people who are knowledgeable about sickle cell disease, right?
Yeah.
Okay.
Yes, they'll be talking as if you send her to the juju place and they bath her, him or her, and she'll be fine. Or if they give her mask,
Wow.
if they even people will
That's
be saying that
a very, very touching story.
yes, even some people will be saying that maybe go start your tummy when you were pregnant, simply because the child was going lame.
We need a lot of education on this.
Is that?
That means we need a lot of education on this. Not for we the normal people, but even for our medical practitioners who are outside the cities. Because from your talk, it seems like most people are not even sure what to do outside the cities. Okay, so let me because of time, let me open it up to about 5 minutes of questions, so people can ask you any questions if they are ready.
Okay.
Okay, guys. So anybody have any question, comment, suggestion, anything? Because from this story, it seems magical. It's a very touching story. As a father with a 3-year-old, almost 4-year-old daughter, this is a very, it touches my heart, because I'm like, so what if it happens to me? What will I do? I'm sure some of you are actually have sickle cell disease, or know people with sickle cell disease. So this is a very good story. So any questions? Just raise your hand and I'll unmute you so you can talk. Okay, I guess we don't have any questions. Okay, so do you have any questions? No? Okay, wait. I have a Priska. Please ask your question. One short on time. Ask your question.
Okay, so I want to know, Auntie Praise, did you know your genotype at that time?
Please, no.
Oh,
By
okay.
the time I was pregnant, I tested SC. The time I was pregnant, I tested SC at our hospital. So after I went to which hospital, you can't be SC. It's either you are AS. So we went to one program at Korle-Bu, and I retested again, and I was
Wait for me, okay?
the doctor was
Okay. Wait more, okay?
Okay, I think that's and me, I always my parents because my mom too didn't know a genotype, so that's what's happened. But we still
they shouldn't be putting the blame on us because but they shouldn't be putting the blame on us.
Okay, thank you very, very much, Miss Praise, for your story. It's a very touching story, like I said, and I'm sure most of us will learn a lot from it. Next we have Miss Sheila. Are you available? Miss Sheila Mensah.
Hello.
Yeah, Miss Sheila Mensah.
Please, I'm here. Hello.
Okay. Miss Sheila Mensah, can you go ahead? Miss Sheila Mensah is also a mother or a parent who lost. Oh, sorry, who has sorry. Miss Sheila Mensah is also going to share her story about sickle cell child. So please go ahead.
Okay. Thank you very much. And sorry for being late.
Oh, no problem.
My name is Sheila Mensah. I have 2 children who are sickle cell, and they are all SS. One is 7 years and one is 4 years. Actually, the 7 years girl had a mouse stroke about 3 years ago. It all happened when I took her to Accra Mall one Friday. So we came back. She slept the following day, early in the morning, Saturday. She said she wanted to pee. Now, so why don't you get up and go and wee? She said, Mommy, I can't get up. I said, what? Why can't you walk? No, I can't walk. I said, what is happening? I didn't know she was sickle cell by then. I said, what is happening? So I tried to made her stand, but she wasn't able to stand. And all what she was doing was that she was just crying. So we took her to rush her to Chumeso Hospital. It was there that we were transferred to 37 Military Hospital, and she was confirmed to be a sickle cell patient. And later they had a series of lab tests, and they said it's mouse stroke. So that's what happened. And since that, it has not been easy because of the mouse stroke. Because of the mouse stroke, she always have they do connect transfusion for every month. So every month we have to go to 37 for blood, because I was told when you don't do it for her, there's likeness that they come back. And now she's able to walk all right, but then she limp on the leg. Yes, she limps on the leg. So that's how far we are managing her. By God's grace, it's okay, but we are still hoping God will do something for us. But what I thank God for is that she's able to walk to school by herself and come home by herself. That's what.
No.
So this is my story.
No, Chichi come and sit here.
Hello.
Yeah, sorry. So it says she's okay now, right?
Yeah, she's fine, but she limps on the leg.
Wow. So at least
she limps.
wow. So compared to Madame Prisia, at least a little,
Sorry?
yes, lucky. If that's the correct word to use. At least
Hello.
you're able to save your. Can you hear me?
Yes, miss, I can hear you now.
Yes, I was saying compared to Madame Praise, who lost her daughter, at least you're a little more blessed, or if that's the correct word to use, because we could have gone in any way. Like we say, only God knows best.
Yes.
Yes. Since we are short on time, let me just go straight to Madame Diana. She's the hematology nurse specialist at the Korle-Bu Teaching Hospital. Madam Diana, are you ready?
Hi. Good evening, everyone.
Good evening, madam. So if you'd like to share your screen, I'm sure when you finish, we have a lot of questions for you. I know I do, so if you can please go ahead.
Okay. Can everybody see my screen now?
Mine is loading. Screen is showing blank.
Yeah, I can see.
Okay, yes, it's on now. So please go ahead.
Right. So good evening, everyone, and I'm so grateful for this opportunity to talk to our sickle cell community about one of the very important topics and one of the complications that affects people with sickle cell disease. Listening to Praise and then Sheila just sent my mind back in the last 3 weeks, where I had to deal with 3 children all coming down with strokes. Thankfully, we were able to save all of them. But at the end of our presentation, we all will appreciate where we've come from and how we'll be able to deal with this devastating complication that results from sickle cell. So today we want to look at sickle cell and the brain. So this will be the outline of my presentation. We'll look at what the brain is and its functions. I'll try as much as possible to make it very simple so everybody will understand. We'll look at a little bit about sickle cell disease, what causes stroke in sickle cell, what is the incidence of stroke in sickle cell disease, are there types and nature of strokes that occur in sickle cell? How do we even diagnose somebody with sickle cell disease? How do we manage them? And then we will look at prevention. So this is just a picture of the brain. This is just to tease your brain. So I'm just going to move away. And this is our usual picture that we all use every day. You have the normal red blood cells with the normal hemoglobin looking all round and nice. And then to my right, you have the sickled cell. They're very rigid, very sticky, and causes all the problems that we know. So as a form of introduction, the brain is a soft mass of supportive tissues with nerves that are connected to the spinal cord. So together, these two tissues and nerves form what we call the central nervous system. Your brain is a very important part of your body as it controls very important functions in our body. Our ability to think, our ability to talk, to feel, see, hear, or even remember things, and even our ability to walk, it's all controlled by the brain. So just a little bit of all of us, signs that we've forgotten. So the brain, we have 3 main parts. So there's a big outer part that controls our reading, our thinking, our speech, and then our hearing. This part of the brain is further divided into 2 halves. And the interesting thing is that the left part of your brain controls the right side of your body, and then the right side of your brain controls your left side of your body. Again, we have another part called the cerebellum, and this is what gives you balance and coordination. Otherwise, I'm sure we'll all be walking like zombies. So this is the part that keeps us in equilibrium. And then we also have what we call the brainstem. This helps with your heartbeats, your blood pressure, your eye movements, and your breathing. So looking back at this, you realize that our brain is something that when it's affected one way or the other, is going to affect a lot of very vital functions in our body. So simply put, a stroke is a sudden interruption in blood supply to the brain. So when we go on, we will notice that it's either due to a blockage in the vessel that is supplying that part of the brain, or there is a bleed. And so a simple definition of a stroke is when there's a sudden interruption in blood supply to your brain. Now, we all know about this picture. So the first one is just your vessel, so the tube that carry oxygen to parts of your body. So you have the red blood cells with hemoglobin in it. So when you look at the picture on top, you see the very nice, round, flexible, normal looking red cells with hemoglobin moving easily through the vessels. When you look at the lower portion, you have all the sickle, sticky, and very hard sickled cells, which tend to block the vessels. And this blockage occurs in every single part of the body of a patient with sickle cell disease. So when it occurs in the joints, then you have pain. It can occur in the eyes, give you problems in the eye. If you're a male, it can block the penis to give you what we call priapism. This same blockage happens in our brain, and that is what we call a stroke. So when the blockage occurs in your brain, then we say that you have suffered a stroke. So originally it was thought that the small vessels in the brain were the cause of stroke. But we've realized that this is not so, but actually it's the larger arteries in the brain that actually leads to the stroke. So if you realize that if any of these are occluded, then it causes dead portions in the brain because there's no oxygen and blood supply to the parts. So this is something that has come up. So it's just not the small vessels, but there are actually huge vessels in there that are causing the strokes. So let's look at a little bit about incidence of stroke in patients with sickle cell disease. So it's estimated that without any form of screening for risk of stroke and interventions put in place, 11% of all patients with sickle cell, especially those with the type SS or what we call or the type S beta tau 0, 11% of all these persons will have a stroke by the age of 20 years. And out of this, 1/4 of all these patients with sickle cell will have a stroke by the age of 45 years. In addition, 20 to 35% of children with sickle cell HBSS or the S beta tau 0 will have what we call a silent infarct or a silent stroke. We'll look into detail what we mean by a silent stroke. Approximately 10% of all children with sickle cell disease will have what we call an overt stroke. So we'll look at what a silent stroke means and what an overt stroke means. So your highest incidence of developing a stroke, if you have sickle cell, is between the ages of 2 years and 5 years, and from 6 years to 9 years, up to the ages of 16 years. So your highest risk of developing a stroke is between the ages of 2 to 5 years. So if you realize, when we listen to our first mother that spoke to us, we realized that her child was just within that age, as well as Sheila, who also shared her story. Both children fall within the highest risk of the ages for developing strokes. So let's look at types of strokes that we have. So we have two basic types of stroke, which is hemorrhagic stroke. So this occurs when you have an injury to a part of the brain and then a bleeding occurs within the brain, okay? So when there's bleeding within the brain, it swells up and causes damage, okay? This damage can be due to the tissue or to the blood vessels within the brain. This type of stroke is common in the adult ages between 20 to 30, and there's a high rate of death associated with this type of stroke. The second type of stroke is what we call the ischemic stroke. So this results from a blockage in the vessels. So the part of the brain that is deprived of oxygen and blood supply sort of dies. So that's what we call the ischemia. And so when this happens, then that part of the brain that doesn't get enough blood dies off, and then whatever function that part of the brain controls is lost fully or partially. So this occurs mainly in children. So by the time the child is 15 years, a lot of the strokes that occur in young children tend to be this type of strokes. And in adults may occur in them when you are over 30 years. So the hemorrhagic is common in adults, while the ischemic one is common in children. So there are basically some risk factors that puts one at risk of developing a stroke. So by virtue of you having sickle cell, the type SS or S beta tau 0 puts you at risk of stroke. But in addition to that, there are certain things that will increase your risk. So when you have somebody that you have the transcranial Doppler velocities being high, we'll look at that. That is how the blood flows through your brain. The speed is very high. Then your risk of developing a stroke is increased. In addition, as you age, then your risk for developing a hemorrhagic stroke increases. If you have somebody whose blood pressure is not controlled, and this is very common in adults with sickle cell disease, where they have pulmonary hypertension, they tend to have issues with their kidneys, issues with their bleeding, they have issues with bleeding. Then these are all people whose risk for stroke is increased. Now in children, again, SS and S beta tau 0. If you're a child who has had a mini stroke, so a mini stroke is basically, you don't show any signs, it's just a very, within 1 hour, all the signs just goes off. If you're a child that have experienced this mini stroke, then you have a high chance of developing a full-blown stroke. If you are somebody who has increased episodes of pain or complications such as acute chest syndrome, then your risk also increases. If you have issues with nervous system infections like what we call encephalitis or meningitis, then your risk also increases. If you have gotten a trauma to the brain, if you have somebody who has history of seizures, so people have like epilepsy, all these increases your risk of developing a stroke. If you are running very low hemoglobin, so you should not be happy if your child is running low hemoglobin. Oh, my child's HB is 6 or 7 or 8, but he or she is not getting sick, so she's fine. She's not fine. These low hemoglobin levels are rather putting the child at risk of developing a stroke. If you have very high white blood cells, that makes your blood thicker and also increases your risk of developing a stroke. If your transcranial Doppler velocities are also very high, then it increases your risk of stroke. So every 1 in 10 children with sickle cell will develop a stroke. But if you have elevated transcranial Doppler, then this risk comes down to 1 in 4. So if you have somebody that you have issues with sleeping, people have what we call sleep apneas, where when they sleep in the night, their oxygen saturations go down, what we call hypoxia, or the tongue falls back. All these will increase your risk of developing a stroke. Now, we've looked at the types of stroke. I want us to look at what the nature of the strokes are. So in my previous slide, you might have heard me mention silent strokes and overt stroke. So a silent stroke in its sense is what we refer to where the person has had a stroke, but there are no signs indicating on the child or adult saying the child has a stroke. So we realized that in our 2 mothers that talked to us, they told us that their children could not walk all of a sudden or lost consciousness. So for them, you could see that, yes, they had some weakness. But in this type of stroke, there is nothing showing on the child. One way of picking them is that a child that is doing very well in school suddenly starts declining. So the parents start beating the child, you are not learning, you are not doing well in school. But once a silent stroke occurs, one of the first things that it affects is the cognitive. So the child doesn't remember things in school, is very slow to appreciate things. And so it is only detected when you do an MRI. That's where you will see that there are small dead areas in the brain. Without that, the only way to pick is when the child's cognition goes down. So these things could be happening there and actually predispose the child to develop a more obvious stroke. So it is estimated that 17% of all children with sickle cell disease before the age of 14 will have a silent stroke, and the rate will increase to 23% by the age of 18. As and when the size of those small dead areas are increasing. So these silent strokes occur in the frontal part of the brain that is responsible for very fine academic achievements and memory. So this is what I've spoken about. So your academic ability is controlled by the frontal part. So if you have a silent stroke, then that is the first things that are affected. So you don't remember things, they become very slow, okay? And the only way to detect is when you do an MRI of the brain. The second one we'll look at is an overt stroke. So overt means you can see, so it's obvious. So the effect of a stroke will depend on which part of the brain is injured and how severely it's injured. So if the occlusion or the bleed is very small, then that part of the brain, the function will be lost partially. But if the bleed is big or the occlusion is big and a larger area is affected, then there are total loss of function of the part. So if you listen to our mothers, all these two children were very fine. The strokes occurred acutely, so all of a sudden. So children are fine, they are going to school, they are going about their normal activities, and all of a sudden they lose consciousness, or they lose the ability to walk, or they have their face twisted to one side, or they have what we call convulsions, or suddenly they are having headaches. So this is a sudden onset of loss of function of a part, inability to walk, or the face shifting to one side. Since different parts of our brain control different areas and functions, it is usually the area immediately surrounding the stroke that is affected. So if the part that is affecting speech, it is the area that the blockage has occurred, then the speech is what will be lost, either totally or partially. So sometimes people who stroke may have headaches, as I've already mentioned, or can have just painless stroke. So the child cannot use the part. It is not paining the child, but he cannot just use the parts. So how do we even diagnose somebody as having a stroke? So like the mother was telling us about, when you come to the hospital, we do take a lot of history from you. We want to find out how it happened, what were some of the things that might have happened to the child before you got to the setting, to the hospital. This helps us to be able to actually determine what type it is, even though the scans will really narrow us down to what type of stroke you have. So it's very important that at this point, you divulge everything that has happened to the doctor that is taking the history from you, or the nurse that is seeing you. Don't assume, oh, they are going to judge me. The thing happened 2 days ago. You say, oh, it just happened an hour ago, because I don't want to reprimand me. The duration is also very important to us. So at this point, we encourage you to tell us exactly what has happened from the onset till you got to the facility. We also would examine you to find out which of the parts that are weak, what is the extent of the functions that have been affected. Again, we do some lab tests. We want to look at your blood level. If you are somebody that we don't know whether you have sickle cell already, we want to test for sickle cell, and also screen for some infections and other necessary things that will help us. We'll do a CT scan. So we'll do a CT scan, we'll do an MRI. These are all to help us look into the brain to see that which parts of the brain have been affected. Is it a bleed that is there, or is an occlusion? There are more advanced tests that we do to actually look at the vessels, the tubes itself that is there. Is it tortured? Or all these helps us to diagnose you as to you having the stroke or not. So how do we manage patients that we identify who have had a stroke? So unfortunately, once you have a stroke, it cannot be cured. So when a tiny part of your brain is injured or affected by a stroke, it never grows back. So once a stroke has happened, unfortunately, the brain has other ways. Fortunately, the brain has other ways of responding to the injury. So you realize that the other parts of the brain try to perform the parts, functions of the parts that have been lost. So that's how we're able to regain certain amounts of the functions that are lost. Now, when you suffer a first stroke and nothing is done about it, you stand a 67% chance of developing another stroke within especially the first 1 year following the stroke. So it's very important that if you develop a first stroke, everything is done to prevent you from developing a second stroke. So what do? The first and most important thing we do is the chronic blood transfusions. So when you come to the hospital and we say your child has suffered a stroke, the most important thing we do is to give the child a blood transfusion. At that point, a lot of the time, we are not transfusing that child because his blood level is low. The idea behind that transfusion is to sort of mix up the child's blood, is to introduce hemoglobin A, red blood cells or hemoglobin to this child so that we reduce the cause of the occlusion that is ongoing. Sometimes if the child's blood level is so high, then we cannot just put blood on the child. Sometimes we do what we call the partial exchange, where we remove some of the blood and then we put it in. So sometimes the parents are worried, my child's blood, the level is 8. That is where it is. Why do you want to give him or her a transfusion? Like your child suffers a stroke, it's important that we give that transfusion to mix up the blood. Now, the ongoing management is what we call the chronic transfusions. So that is the standard management for preventing subsequent transfusions. So if you listen to Sheila says every month she takes the child to hospital to have a blood transfusion. The whole idea is that when you have sickle cell, you have a high percentage of hemoglobin S. So as we transfuse you every month, the whole idea is to reduce your hemoglobin S level to at least 30%, and that will prevent you from developing a subsequent stroke. So the child goes into hospital, has the transfusion, and goes on. Why do we do 4 weekly? Because if I transfuse you today, after 4 weeks, your body will make up use of all the hemoglobin A that has been transfused, and then your S levels will go up again. So we need to replenish this. Even though that is the gold standard for preventing strokes, it also comes with its issues. So even though the blood that we give to you is absolutely screened for some of the viral infections, that is hepatitis B, C, and HIV, there's always still a 0.1% chance of you getting these infections. So as you are on the transfusions, before we start, we want to see your status. And then every 6 months to 1 year, we want to check and see whether you develop these viral infections. Again, each transfusion that you receive introduces some amount of iron into your body, which the body is not able to remove the iron at the rate at which the blood transfusions are being given. So after 10 to 12 transfusions, you build up these ions in you. And if medicines are not given to remove these ions, can start causing damage to your heart and then your liver. So everywhere in the world, once you have a first stroke, or even your velocities are very high, you are put on chronic transfusions for long term, where you can get the iron medications for free. In our part of the world here, this is very difficult for us to do because 1, we are not getting access to the iron medication. 2, it is very, very expensive. And so sometimes we give the transfusions up to a point and introduce another option, which I am going to talk to briefly, that also works in preventing the stroke, but not as effective as the blood transfusion. So that takes me to the second option, which is hydroxyurea. And I'm not going to talk a lot about hydroxyurea because we'll get another opportunity to speak into details about hydroxyurea. But hydroxyurea also plays a part in preventing another stroke. It's very effective if the first stroke has not happened and you are preventing it from happening. Again, in the absence of feasibility of doing chronic transfusions, you consider giving the child hydroxyurea, which increases the fetal hemoglobin and also prevents the child from getting a stroke. So from what I've told you, you realize that there's no option of saying that, yes, my child has had a stroke. My choice is that I will not do anything for my child. No. Then you are risking the child from getting a stroke. So once the stroke happens, they're doing the counseling, all these options are put across, and between the clinician and the parents, the best options that are right to prevent the child from getting worse. Again, you can consider a bone marrow transplant for children who have had strokes to prevent subsequent, and of course, that is the only curative way of preventing strokes. Now, still on the management. So what I talked about is what your hematologist or what your doctor will do to prevent subsequent strokes from coming. Now, this is a child that has developed stroke and has lost some of the functions. So retraining the parts of the brain to do different jobs is a very taxing task. So it is very slow and very difficult. So we realized that the first mother that shared with us kept on saying, the child says, I want to use my hand. But then you need to retrain the brain to tell the hand that you have to move up. So once you lose the function, then we need to gradually help the brain and help the functions to return. What I have to put here is that there is no guarantee that we are going to return your child back to 100% as the child was before. But the whole goal here is to return the child back to independence. So we realized that Sheila had told us that when it happened, the child was not able to walk, but now the child is able to walk and then what? Go to school. So that is achieving some quality of life. So you wouldn't want to say that my child should return 100%. Some children are able to recover with no deficits at all. Some children again recover. Some the speech don't come back again. Some the speech comes back, but it is slurred. Some lose their hearing, and some lose their mobility entirely. So they need to be carried around because they cannot walk. Some are also left with seizures, so they have to be put on seizure medications. So there are few people who, in addition to the hematologist, also take care of your children. So we have the physiotherapist, which as soon as the stroke happens, as soon as the child is stable, we get the physio person to be in to help with the mobility of the part that is affected. And it's important that the child continues the physio as recommended by the physiotherapist. The speech therapist may come in if the child has lost their speech. We also have people we call the occupational therapy. What they do is that you see that when you lose function, then the child cannot hold the spoon to be able to feed themselves. The child cannot hold the spoon to bath. So all these people, the occupational therapy people, come in to help you perform activities of daily living. And so they help in recovery of certain functions for the children. And then one important person that also comes into the team is a clinical psychologist. So they help the parents to deal with the stroke. So you heard our first mother say that sometimes she becomes very frustrated and she wants to beat the child because the child wants to walk, the child cannot walk, and it becomes a daunting burden on the parents and the child themselves. So you need a clinical psychologist to help these parents to cope with it and the child to cope with it. Another function that the clinical psychologist performs is to do what we call a neurocognitive assessment. So remember that we said that the children who have the silent stroke or those who have the overt strokes, it affects their cognition, that is their academics. So they perform specific tests on them to identify which areas of learning that they are deficient in. And they actually help the teachers to help these children and the parents so that you don't start beating the child that you are not learning. But once we identify the problems, then we together help the children to return back as much as possible. And also help the teachers as the child goes back to school to know that something has happened to this child. And aside, the child is not going to perform as they used to be. And so you need to help them out. So if the child has a seizure, then we'll refer you to the neurologist to also follow up on that. Now, how do we prevent a stroke from happening? So we know that your highest risk of developing a stroke is from the age of 2. So we have what we call a transcranial Doppler ultrasound. So it's a scan that is similar to the scans that are done when you are pregnant. So these scans actually measure how blood is flowing through the brain. So if the speed is above 200 meters per second, then it's commensurate with your risk of developing a stroke. So it is important that any child that has sickle cell with a type SS or S beta tau 0, as soon as the child turns 2, should have this scan done, so that we'll be able to pick that 1 in 10 children who are at risk of developing a stroke, so that interventions can be put into place to prevent the stroke from happening. And this scan, unfortunately, we don't have the scan available where you can use your insurance to do it. It is available on private basis, and patients have to pay for it. Currently, we are paying 350 cedis to have the scan done. And if it is normal, it is done once a year. If it is abnormal, then your hematologist or your doctor following you up for the sickle cell, after putting in interventions, will determine how frequent this scan is supposed to be done. I know that this scan is not available outside Accra and then Kumasi. So if you find yourself outside these two regions, or even here in Accra, it is not every facility that has the transcranial Doppler. So it's important that wherever you find yourself and your child is being followed up, you need to speak to your doctor that once in a while you can come down to Accra or Kumasi, depending which one is nearer to you. So your child can have this scan done, and then interpretation will be done, and then the necessary interventions would be put to place. So the transcranial will be done between the ages of 2 and 16 years. After 16 years, you cannot use this transcranial Doppler to predict a child's chance of developing a stroke. Research has shown that these children who we have used the scans to pick up those who are at risk of developing a stroke have actually reduced the number of children who have had the strokes. And so it's important that we have these scans done to pick the children. So this slide just shows a child having the transcranial Doppler being done. And so if you see, it's a very simple scan that is being done. And then the velocities are read to you, and then your doctor will interpret it for you. So to conclude my presentation, it's important that we screen early for children who are at risk of developing strokes. It's important that when your child has developed a stroke, you prevent a second stroke from happening. And then it's important that those who have the risk factors, we put in one of the disease-modifying measures to prevent the child from developing the stroke. Together, we can achieve more. There is help everywhere. And then we are around to offer that support for you. Thank you.
Thank you very much, Madam Diana, for your very, very good talk. I guess let me start with the questions. You said the transcranial Doppler is done once a year, right?
Yes, that is if it is normal.
Okay. So
Yes,
let's say between that, the first and the second one, something happens. Is there any other way to know if your child is at risk of stroke?
So once we've done the first one and your child is normal, we still encourage you that yes, it is normal, but the sickle cell is still there. So if you notice any of the signs that I talked about, your child is complaining of headaches or suddenly it's not working, you need to check. So the scan now becomes a sort of a screening tool, but it is not an absolute determinant. Yes.
Okay, thank you. Do you have any questions? This is a very, very educational talk. I'm sure we have some.
I do have a question.
Was it Priska?
Yes.
Yes, please go ahead.
Okay, so I want to know, does it mean that everyone who has sickle cell has a chance of getting a stroke? Because most of my family members are sickle cell, and I think it's just one that's had stroke, but the rest of us are okay. So I want to know if by all means you are going to get a stroke.
So by virtue of you having sickle cell, the SS or the S beta tau 0, that alone puts you at risk of developing a stroke. And like I said, the years from 2 to 16 for the ischemic, and then the hemorrhagic when you're an adult. That is why it's very important that if you notice any symptoms, you need to check yourself into hospital for us to be able to assess whether you've developed a stroke or not. But by virtue of you having sickle cell, the type SS or S beta tau, you are at risk of developing.
Okay, Priska, I hope that answers your question.
That one is but I don't know, but so now, so meaning what I want to know is there is no chance of escaping or what? That's what I want to know.
So if you remember, I've said that there are 1 in 10 chances or 1 in every 10 people who will develop a stroke. But then it is very difficult for you to pinpoint who that 1 in 10 is. So that's why we looked at the risk factors. So if you're somebody whose HB is very low, your white blood cells are also very high, you are falling within the ages, you have hypertension, which is not being controlled, then these are the things that will further increase your risk. Is that okay? So that is why the yearly screening for complications is very, very important. So sometimes when persons with sickle cell grow up, they tend to say, oh, I'm fine, I don't need to go to hospital. I don't have pain. It is not only the pain. There are lots more things that will be happening in your body apart from the pain that you need to be assessed for and screened for, okay?
Okay, but normally if we should go for our regular checkups, they don't tell us that we have to go for a screening or something. All they do is they check our malaria. I don't know the test they do, but after that, then you are good to go home. So how would you know that, okay, it's time for me to go and scan and I'm at a risk of having a stroke or something? Because they don't tell us that you have to be going through scans and all that.
All right, so how we take care of you depends on your age. So like I said, I am in the pediatric clinic. So we know that as soon as we are seeing you and your child is 2 years, we tell you that your child needs to have this scan because of the risk of stroke. When that child gets to age 8, if the child is SC, we start looking for problems that can happen in the eyes. So we know the complications that occur with the various stages. And so we actively will screen for. As you come in, there are times they tell you to go and do your kidney test, they tell you go and do your liver function, in addition to your blood workup that you do every time. So you realize at a point in time, they'll ask you to go and see the eye specialist. If you do your kidney test and there's a problem, they will refer you to see the kidney specialist. So these are all things that need to be done. And so you need to also talk to your doctor. Okay, so it's not everybody that has access to a place where a comprehensive sickle cell clinic is being run. Okay, so if you have a place where a comprehensive sickle cell clinic is being run, then they will screen you for all these complications. Is that okay? But if you are not, then there's something that you need to discuss with your doctor. If you are an adult or you have sickle cell, every 6 months to 1 year, you need to have your kidney and liver function test done and a urine test done. If you're a child below 16, you need to have your yearly TCD done and then check your eyes and all that. So please, the next time you visit your doctor, ask your doctor, I am at this age, what things do I need to be screened for to prevent certain complications? Are we okay?
Okay, I think I'm okay.
Okay, thank you. We have a few questions on the group. Someone has just asked if you're at risk if your BP is always low.
So your BP being low or high also has its own issues. So you realize that those who are running very low BPs, you've been referred to see the cardiologist and all that, just to make sure that all those things are dealt with. So either your blood level is high, then that can predispose you to getting those bleeding episodes that happen in the brain. Is that okay? So your hypertension could also cause other things and also predispose you to developing the stroke. Are we okay?
Okay. And I have another one. Signs of strokes in adults. Is numbness of the lips associated with stroke?
So when you have numbness at the extremities, it could be a lot of things, okay? We need to screen you for other things to see that what it is. So that's why the initial examination is very, very important, because a lot of things can make you have numbness. So as you speak to your doctor will ask you further investigations and do further examination to be able to see that is your numbness coming from your sickle cell, is it a stroke or something else that is causing it? So this person needs to be evaluated further for us to determine what the numbness is, the cause.
Okay. Thank you. We have a question from Madam Praise, I believe. Madam Praise, can go ahead. Can go ahead.
Thank you. I want to ask, what is it that if you are the and you are seeing no improvement, referred. Why is this so? And the second question is, after we went
I didn't
to
get your first question.
my question is, why if you are the, let me say I'm at Margaret Marquardt at Bandu.
Okay.
I'm seeing no improvement, and the doctors will be coming and doing whatever that they will not say, okay, because we can't do what is happening. Ask for it. And my second question, what do you have? I said, you have morphine. He said, no, what this guy is morphine. And that morphine, I've not heard of it before in our place. Why? I want to ask why.
All right. So the first question, like I said, if you find yourself in a place where you don't have access to comprehensive sickle cell, so when your child has sickle cell disease, your visit to the hospital is not only when the child is sick. No. The child has to be followed up in a place where they have a sickle cell clinic. So if you find yourself in Pando, they run a sickle cell clinic in Trafalgar. Is that okay? So you should be given a referral where you followed up at the sickle cell clinic at Trafalgar. But if the child is not feeling well, then you can be seen at the Pando hospital. And if the doctors at Pando think, oh, okay, this problem you presented at this time, you need to go to Trafalgar, then they will refer you. But it's important that your child be referred to a place where they are doing a comprehensive sickle cell clinic, that these screening things can be happening. For your second question about morphine, morphine is a painkiller. So I'll use that as well. So we have levels of pain medications that we use depending on how severe your pain is. So if your pain is mild, we want to give you some paracetamol. If your pain is moderate, we can add brufen to the paracetamol. If your pain is very severe, then we move to morphine. So morphine is a medication that is very protected. And so you wouldn't want to give it whilst you are home. You want the person to be in hospital for the doctor to determine what dose is appropriate for you to have. But then if you are in a hospital that your child's pain is not being controlled by either paracetamol or brufen, which is the lowest, then they need to escalate to morphine. But it's not every facility that has the morphine. Some people have other alternatives that they use. But then if the pain is not resolving on lower painkillers, then the doctor will assess you and move you up. So morphine is generally medication that is used for severe pain. Yeah.
Okay, but at times if you the parent or caregiver, you ask for referral. At times when not in a good handles, and that means what you are doing here, that means you are not appreciating it. Why do you ask for referral? Are we not nurses? Are we not doctors? That's the answer that they at times give you.
So that is very unfortunate. Is that okay? Because anybody operating at a level, you have limitations to what you can do and what you cannot do. Because in Pando, they don't have the transcranial Doppler there. So if they are keeping you there, there's no way you can have access to that. Is that okay? Even at Trafalgar, they don't have the transcranial Doppler there. That means for those of you in that part, you have to come to Accra. That's why I'm saying that it is the levels of the management. I don't think if you are going to Trafalgar, you will need a referral from Pando. I think you can walk into Trafalgar and book into their sickle cell clinic. Is that okay? It is when you are moving to a teaching hospital that you will need a referral. I stand to be corrected, but it is something that your doctor or nurse should be open to that discussion that, you know something, I have learned that my child needs to be followed up at a sickle cell clinic. But since you don't hold a sickle cell clinic yet, can you refer me to here that they have a sickle cell clinic? They say if my child is not well, I can come here. That does not mean you are not capable of taking care of me, but there are services that my child requires that you will not be able to provide for me here. So it is a dialogue or conversation you should be able to have with your doctor or nurse. So don't feel that they will feel offended that they can't take care of you. That's why you are leaving. Is that okay?
Okay.
Okay, thank you. We have a question from Madam Naomi. If you can unmute and ask your question.
Yeah, please, good evening once again. My question is about the stroke issue. I've been having acute chest problems like once in a while. By any time I have that crisis, it's so serious that sometimes I'll not even know when I'll be taken to the hospital. So my parents don't allow me to stay alone. But here lies the case, I'm working at a different environment and I'm always alone at where I am. And anytime I go to the hospital too, I have my BP is always low. So I don't know what I can do or what is the best option for me, whether I should seek for a referral to another hospital or not, because here we don't have a sickle cell clinic. And I had to try to explain to a doctor I came into contact with because of some drugs that she was issuing without lab tests and other things, and she got angry. So I don't know how best I can manage myself if I'm alone and maybe I have crisis and I have to get to a hospital for treatment.
If I may ask, where are you currently?
I'm in the Volta region.
You are in the Volta region?
Yes, please.
Okay, so how far are you from Trafalgar?
Hey, very far, about 3 to 4 hours.
Okay, so you coming to Korle-Bu and you going to Trafalgar, which one is shorter?
Okay, actually, I go to Tama General Hospital for sickle cell clinic.
Okay.
Yes, please.
Okay, so what I will say is that speak to Dr. Luda. You know Dr. Asmeni?
Yes, please.
Yes.
She's the one who I've been taking care of.
Good. Are you on Hydroxyurea?
No, please.
Okay. So what I want you to do is when you next visit her, have a discussion with her concerning your issues with the low blood pressure and the fact that you've had recurrent acute chest syndrome. It will be good for them to have a conversation with you and to consider if you want to go on hydroxyurea. Concerning the difficulty you are having with the hospital that you find yourself, let Dr. Sumeni give you a very small medical report, okay?
Okay.
That are there, stating what you are being managed on in Tema General Hospital and what they want to be done for you when you have pain or you have issues. Is that okay? Because acute is a very serious thing that if it happens to you and whoever is taking care of you does not know how to manage it, can cause a lot of problems. Is that okay? So I would say that as soon as possible, visit your Tema General, visit your clinic, discuss with Dr. Asmeni these challenges you are having. Let her give you a small medical report back to where you are, and also have a discussion on hydroxyurea with her. Is that okay?
Okay, thank you very much.
You're welcome.
Okay, thank you. I don't think we have any more questions. We've gone over our time. Madam Diana was so good that we actually passed our time. I'd like to say a big thank you to Madam Praise and Madam Sheila for sharing their stories with us. I know it must be hard, but thank you very much for sharing with us. Thank you for all those who asked questions, all those participated. I hope we've all learned something good today. Our next session will be in 2 weeks. We will share the flyer as soon as it comes out. And Madam Diana, thank you very much once again. As for you, dear, you know you are my favorite person in the world. Anytime I see you, I want to give you a big hug, but now COVID.
And mine too.
Thank you very, very much.
Okay, take care.
I'm sorry?
Thank you, Auntie Dinah. Thank you.
Thank you too, and take care.
And hopefully we'll see you too. Everybody have a good week, a good weekend, and stay blessed.
Hi, Dinah.
Wish you
Hello.
same.
Hi, bye, Dinah.
Bye.
That was a good presentation.
Thank you. Hey,
That's
that's my
Agnes.
colleague.
Okay.
All right. Thank you, everyone. Have a blessed
Bye.
Leave.